morning everyone. We are continuing today with Ecmo series, and today's session is on plasmapharesis on Ecmo. So now coming to introduction, as we all know, ICUs are specialized treatment departments of patients requiring close monitoring and critical care, including pharmacological or mechanical organ support due to hemodynamic instability or organ failure. Therapeutic plasmapharesis, that is TPE, is a part of intensivist armamentarium of life-saving therapeutic interventions for otherwise life-threatening conditions and is commonly used as a primary adjunct therapy if clinically indicated. TPE is an extracorporeal procedure that removes plasma from other blood components and replaces it with 5% albumin and or FFP. Now coming to indications of TPE. Basically, the American Society of Apheresis has given an extensive list of indications, but basically for our purpose of understanding, we can divide the indications broadly into two categories. First is for removal of pathologic elements from circulation, for example autoantibodies, toxins, cytokines, adhesion molecules, etc. via apheresis in order to reverse a pathologic process. Examples of this category include autoimmune mediated conditions including neurological disorders, graft rejections or infectious diseases. Second indication is substitution of missing or inactivated protective plasma factors through healthy donor plasma. Examples are thrombotic thrombocytopenic purpura, a potentially fatal thrombotic macroangiopathy resulting from inefficacy of one wilminate factor cleaving protease ADA-MTS13 and subsequent disseminated thrombotic events. Now coming to procedure per se, separation of plasma and cellular components is achieved by centrifugal forces or membrane filtration. While cellular components are usually returned to the patient, they can also be deliberately removed, for example in patients at risk of leukostasis, or they may be even harvested, that is called cytopharesis, to perform hematopoietic stem cell transplantation. So basically there are certain differences between centrifugal force and membrane filtration. First is the mechanism, where in centrifugal technique centrifugal force is used, whereas membrane filtration uses capillary membrane filter. Then plasma extraction achieved is 80% with centrifugal force, whereas it is only about 30% using membrane filtration. Anticoagulation is citrate anticoagulation with centrifugal force, whereas it is with heparin or bivaleuridine with membrane filtration. Separation is based on specific gravity with centrifugal force, whereas it is based on molecular size with membrane filtration. Blood volume in the circuit is about 180 ml with centrifugal force, whereas it is about 125 ml with membrane filtration. Molecular weight is not applicable to centrifugal plasmapharesis using centrifugal force because it is basically based on the specific gravity. Whereas membrane filtration has a cutoff of 3000 kilodaltons for filtration. Fluid replacement, in both cases albumin or fresh frozen plasma can be used. Single or multiple TPE sessions lasting for 3 to 4 hours can be performed in isolation or in tandem with other extracorporeal therapies, including ECLS and or continuous kidney replacement therapy, that is CKRT. The amount of plasma exchanged with each treatment course can vary and is typically 1 to 2 times the total plasma volume. So this is basically a circuit which shows the apheresis system which is incorporated into Ecmo circuit. So this is basically a picture depicting VA Ecmo, where the blood is drawn from the femoral vein to the centrifugal pump, then to the oxygenator, and one line from oxygenator is directed towards the apheresis system where therapeutic apheresis is carried out, and then the filtrate is returned back to the patient through the femoral artery. This is another diagram in which the plasmapharesis is separate from the ECLS circuit, which also has integrated CRRT circuit. The tip of VA Ecmo access cannula sits in the right atrium and return is in the left femoral artery. CRRT circuit runs off the Ecmo circuit, and TP is performed by using a dialysis catheter which is inserted in the left internal jugular vein. Now coming to some study results. Basically there is overall a paucity of data on use of TP with ECLS. American Society of Apheresis recently updated the guidelines and encompasses a broad range of conditions graded by level of evidence. TP in tandem with ECLS is most reported in patients with septic shock and multisystem organ failure. But in this case also it is a class 3 recommendation, that is grade 2B, that is weak recommendation with moderate quality evidence. TP is thought to improve organ function in sepsis by removing inflammatory mediators and replenishing anticoagulant proteins. There was also an improvement in mortality in the retrospective study of pediatric patients with thrombocytopenia associated multiple organ failure. Unfortunately, prospective studies evaluating the use of TPE in children and adults have been largely conflicting, and a large systematic review and meta-analysis concluded that there was insufficient evidence to recommend TPE as an adjunctive therapy for patients with septic shock. So, larger studies are validated in this case. Nguyen and colleagues performed a randomized controlled trial in children with thrombocytopenia associated multiple organ failure and found that no patients who received TP died, while 80% of those who were randomized to standard sepsis management died. In ECLS supported patients with critical cardiac disease and thrombocytopenia associated multiple organ failure, TP use was associated with recovery from organ failure. Case reports on use of TP in COVID patients on Ecmo are also available in literature. Study by Houston et al. They concluded that single pass plasmapharesis can reduce the Ecmo-related severe hemolysis and is able to reduce plasma-free hemoglobin. This in turn also can mitigate the incidence of AKI in long-term Ecmo patients. Utility of TP in acute thyrotoxicosis, which is refractory to conventional therapy, has also been reported in a case study. It was used in a patient who presented with severe thyrotoxicosis with cardiogenic shock and required VA Ecmo after she was on maximum vasopressor therapy despite of conventional treatment of thyroid storm. There are certain concerns which are associated with TP. First of all, the volume overload. The utilization of blood products and fluid replacement is a common concern in simultaneous Ecmo and TP. Basically, only two solutions are used. First is 5% albumin, which is favored in certain situations as it is isoosmotic with plasma, sterile, and can be stored at room temperature, and also avoids risk of FFP exposure and infections. But most of the times FFP is the preferred replacement fluid because most of the patients are post-operative patients and already are in multisystem organ failure. They require all the coagulation factors that FFP provides. Second is hemodynamic instability, which is also an important concern in patients being treated with two extracorporeal circuits simultaneously and undergoing large volume plasma exchanges. Third is hypocalcemia, which is a very important and very frequent complication which is encountered during TPA procedures. It usually results from the use of anticoagulant citrate, which binds to free calcium. Frequent monitoring of calcium and calcium supplementation is thus advised during these procedures. And last concern is transfusion reactions. These patients are already in multisystem organ failure and are immunologically dysfunctional, so there are very high chances of transfusion reactions in them. Now coming to just a word on therapeutic cytopheresis and hemadsorption. Therapeutic cytopheresis, it refers to removal of cellular components of blood, RBC exchange, in which patients' native RBCs are removed and replaced with donor RBCs, is commonly performed in patients with complications of sickle cell anemia such as neurologic changes from stroke or acute chest syndrome. The removal of WBCs, that is called leukocytopheresis, has also been used to reduce the hyperviscosity and symptoms of severely elevated WBCs as in acute leukemia. One of the most reported indications is therapeutic leukocytopheresis in infants with pertussis supported on Ecmo. These infants usually have severe pulmonary hypertension and refractory cardiogenic shock. Hemadsorption therapies. In recent decades, extracorporeal hemadsorption has been suggested as an adjunctive treatment option for different clinical conditions, particularly for patients in severe inflammatory states. Hemadsorption devices have to be incorporated in the extracorporeal blood circuits. Therefore, their use in combination with ECLS is feasible. This is a diagram showing incorporation of hemadsorption filter in the Ecmo circuit. In the first part, you can see that the hemadsorption filter is incorporated in the Ecmo circuit along with the CRRT circuit, and in the second picture, only hemadsorption filter is incorporated in the Ecmo circuit. The inflow to the hemadsorption is obtained through the post oxygenator line, and the return from the hemadsorption is onto the venous side of the circuit. This configuration is important to be maintained. Taken together, there may be sound pathophysiological rationale for the combination of use of hemadsorption and ECLS, and its technical application is feasible and seemingly safe. However, current evidence does not support its routine clinical use, and larger prospective studies are validated. Thank you.